Welcome to the Weatherford College EMS Podcast. This is episode 3, where education meets experience and textbooks meet the street. I'm your host, Tyler Holland, also known as the NIH Man, joined by our resident EMS historian, Adam Parrish, and the been there, done that career guru, Samantha Grimsley. Today we're kicking off a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. So we'll go ahead and get started. We're going to be talking about labetalol, metoprolol, nicardipine, and furosemide.
Yeah, so today's topic is going to be about antihypertensive medications. And one of the things I was talking with Adam earlier today is how often do we really run a hypertensive emergency in the pre-hospital setting? And it's far and few between.
Yeah, it's a pretty rare call.
Most of the time when we're running these patients, it's a confirmed stroke patient where they're being transferred to another facility and we are trying to lower their blood pressure into that threshold. Or we have a preeclamptic mom who, again, we know that that's what's going on and we are, fixing their blood pressure in that sense. But, when we talk about hypertensive emergencies, we can ask all the questions of, do you have the ringing in the ears, the blurred vision, the headache, and everything of that sort? But unless we specifically know that that's the problem, it's not always the greatest thing to be playing with these people's blood pressure. And so I wanted to touch base really quickly on reiterating that there is the difference between a hypertensive urgency and a hypertensive crisis. Urgency is, while we recognize that their blood pressure is elevated, there's no progressive target organ dysfunction. Whereas with crisis, we have that severe elevation of a blood pressure that's greater than 180 over 120, and there's evidence of impeding or a progressive target organ dysfunction. Kind of like when we talk about sepsis and MODS and things of those things. But nonetheless, we're going to reduce the blood pressure because we don't want to damage the organs. That's why we're fixing it in that sense. And we've got to make sure that we reduce for the MAP, not the blood pressure, but the MAP is the biggest thing. And we don't want to go more than 25% within the hour because then we take away their compensatory mechanisms. So if they're stable, we'll reduce to that 160 over 100 or 160 over 110 within the next few hours, which isn't going to be for us in the field. That's going to be in that hospital setting.
Hope not.
I hope I'm not. But then again, there are patients that we're just not going to do this for. And those are our patients that we know there's maybe an ischemic stroke suspicion going on, or there's no clear evidence to support why they're having this immediate hypertensive emergency, because we're not the ones that are diagnosing this in the field for the very first time. There is a trending factor the doctors have figured out that this is going on. Or in the other instance, we have to be careful with our aortic dissections because we've got to make sure we keep that MAP, at a specific range and not take away that threshold either. So that's on the crisis side, but then you got to talk about hypertension in pregnancies, and that's a whole different ballgame of numbers. Anything that's greater than 140 over 90 is considered hypertensive in the pregnancies. And so, again, when we have those patients, we're trying to maintain that blood pressure at 160 over 110, which is realistically not the greatest in everything. So that's my 2 cents on just kind of touching base on those. As we talk about it, you mentioned some drugs we're going to start off with, and let's just start it off with labetalol. I think that's the most commonly used one in the pre-hospital setting, although Adam will say he's got a favorite. He'll bring it up later.
I do have a favorite.
I can say I truthfully have given labetalol in the field. Didn't see a whole lot out of it.
No.
But, when we're dealing with these patients in the field with labetalol, what's it like when managing a hypertensive patient? What are you guys seeing? What might labetalol be as far as the preferred beta blocker? Why are we using it?
Well, labetalol being a beta blocker, let's start off with what that means, right? So I've talked about alpha before. Now let's talk about beta. And what we're going to do is we're going to slow the heart down. And by slowing the heart down, what we're going to achieve is a lower cardiac output. Your lower cardiac output is then going to lead to a lower blood pressure, okay? You need to know that that's how that works, right? And that's the easy way to talk about that.
Mm-hmm.
The next thing to think about is, okay, so how quickly is this going to work? I know I've given labetalol many times, as Sam was talking as well. I've never really seen it do its thing. Now, we can always make the argument that we have several drugs that are that way, right? We give corticosteroids like that because we know it will work. It's just not going to work for us. We know it's going to be beneficial. It's just not going to be beneficial for us.
Mm-hmm.
And the sooner that we get that process started, the better it's going to be for the patient. And one of the things when we start talking about labetalol specifically, it is one of those drugs that it's going to take a while to kick in.
Yep.
And the nice thing about that is that while it's doing its thing, while it's starting to slow the heart rate down and everything, we can then turn around and manage that patient a little bit more effectively over time. And that's why a lot of people like to use it, especially in the hospital sense. So that if you give a little bit too much, that's okay. We can manage this because we're not going to necessarily see a precipitous drop in blood pressure. We're not going to see a precipitous drop in the heart rate. We're going to watch it slowly move over time. And if we need to do something about that, we can correct that as well. And that's one of the big reasons why it's preferred, is that it's not just going to drop them. And one of the big things that you talked about just now too is hypertension as a compensatory mechanism. We need to be very careful, just like when we talk about any other advanced procedure that we do. When we start messing with compensatory mechanisms, we start truly changing the functionality of the way the body works. And in some cases it's needed, and in other cases it's absolutely horrible. We talk about vent management and changing pH. We talk about all kinds of things like that. And we start messing with that, we can really mess something up long term for our patient. The thing with labetalol is that because it is a slower acting drug, we can give it and we can then manage that patient more effectively over time.
Yeah, I think one of the things I struggled with when I was giving labetalol is the dosing of it, because you have to keep doubling it. So if you give 40, then you got to give 80, and then you got to give 160. It's not just keep adding 40 on. You have to keep that trending factor. And in that instance, when I had it for that patient, I got all the way up to 160 milligrams, and I still wasn't seeing any reduction in their blood pressure, let alone their MAP. And so, at that point, we were flying the patient to JPS because she was preeclamptic, and I said, we're almost there. We'll just go ahead and allow them to take care of this when we get there. Yeah. Do you have patients that you think that labetalol should be avoided in? I mean, the common trend that we see is like bradycardia, second and third degree AV blocks, asthma, and any kind of signs of cardiogenic shock. Like, why is that a risky choice in those patients?
Well, kind of like I talked about earlier, if you're going to block up that beta response, it's going to slow the heart rate down. And just like I talked about earlier, lowering that cardiac output is exactly the problem when we start talking about cardiogenic shock. It's exactly the problem when we start talking about bradycardia. It's going to make all of those things worse. Now, she talked about the second and third degree AV blocks. A lot of times those are going to be bradycardic rhythms. Okay, that's the big thing. So we're talking about cardiac output. That's why it's so important to be able to look at that and understand both the cardiac output side of things as well as the MAP.
Yeah.
What about the asthmatic patients? Like, why is that a big thing?
Well, whenever you're giving a beta blocker now and you have an asthmatic patient, you run the risk of that beta blocker potentially causing some bronchospasms, because we know that stimulating your beta receptors can help prevent bronchospasms. If you're blocking them, now you no longer have that mechanism there, and that just goes to the entire mechanism of action behind these drugs and the fact that they block it, they turn off the gas pedal. So that's why you might not see an immediate reaction like some other drugs, like just for instance nitroglycerin. You give nitroglycerin, usually you're going to see a pretty quick onset of action for those drugs. But with this, you're just cutting off the gas pedal. It's not going to make an immediate change. It's going to the body's going to have to start making those adjustments. And like you're saying, if it's a compensatory mechanism, then the body's adjustments are going to get all fouled up in that. So we got to be very diligent and careful whenever we're assessing our patients. And the interesting thing about labetalol is it's also an alpha-1 blocker as well. So it's not completely and solely a beta blocker. It also does have some alpha-1 effects to help prevent peripheral vasoconstriction as well.
So on the spectrum of things, we know our LOLs are having to do with betas. Where does metoprolol come into play in all of this?
Well, metoprolol is a fantastic drug.
I agree. I've used it. I've seen it work. I can say I've seen this one work.
Yeah, it's one of those things that can be used even in the presence of like a heart attack. And it's one of those drugs that it's almost kind of in the same realm as amiodarone in that you can use it in so many different ways. Mm-hmm. And it works. One of the things that we need to make sure of is to either supply the body with the oxygen that it demands.
Yep.
Right? At all times.
How do we do that? We reduce the heart rate.
Reduce the heart rate. Make it easier for the heart to do what it needs to do on what it already has. And with the hopes that then we can catch up as we intubate or do whatever and fix those oxygen problems. The other thing is that, it really helps with contractility. Mm-hmm. It's going to lessen the need to squeeze so hard. And because of that, that's how it ultimately leads to a lessening of the myocardial oxygen demand.
Tyler, did you find anything about this medication having alpha principles? I know it is a beta-1 selective blocker, but what about on the alpha side?
There's nothing here that's saying that it is going to have any effects on our alpha receptors. It's beta-1 and beta-2 only.
So as far as metoprolol goes, we know we also use it in our antiarrhythmics, specifically like AFib with RVR or our narrow complex tachycardias. I mean, we've talked about that in our antiarrhythmic chapter, but nevertheless, is there another way, or have you guys seen metoprolol used in the field where you found something very interesting about it? I mean, I know for myself, it has to be given over a time. I found myself enjoying just pushing a little here and a little there and going that route with it, whether instead of putting it on a full-on drip.
Yeah, titrate to effect is fun.
Yeah,
sure is.
Yeah, but metoprolol is again one of those things that we can. It's a tool for a toolbox, right? It may not be the number one go-to for AFib RVRs, things like that, but you need to know that it definitely, if it's not the primary, depending on your policies and protocols and what your doctor feels and everything else, it's definitely something that's an option, and it's something that you need to be familiar with. And again, it's one of those kind of things that it works on a couple of different levels, and because of that, it can be very effective.
Yeah, and you brought up a while ago giving metoprolol to that patient that's having an MI. Mm-hmm. One of the benefits of that is that it helps to prevent lethal dysrhythmias like VTAC and VFib that's so common in those patients. Mm-hmm. So it's gonna treat the blood pressure and help with the myocardial oxygenation, but it's also gonna help prevent the deadly rhythms from occurring, because it affects on pretty much all of the cardiac cells. It really helps with the sinoatrial node, AV node, and the ventricular myocardium as well.
So let's switch pace over to a calcium channel blocker, which Adam absolutely loves this medication, nicardipine.
It's my favorite.
Let's hear why it's your favorite medication.
So much like the previous comment that I made, titrating to effect is fun. Okay, this is the ultimate in titrating to effect is fun when it comes to affecting blood pressure. Now, with cardine, otherwise known as cardipine, it's very, very powerful.
Mm-hmm.
I mean, we're talking, milligrams per hour when we start talking about this dose. Generally, you're going to start at 5, and you're only going to move it up by 2.5 every so often. And honestly, I've only ever had to raise it from 5 one time. And in fact, I've found that in a few patients that it's been too much at 5 and had to actually go down to 2.5 from there. But I had to call for orders, so you always have that. Now, the thing with this is cardine is a calcium channel blocker. It is one of the strongest medications that we have for this. It acts very quickly, and it is extraordinarily effective. Now, and I know we've already talked a little bit about it, but we really don't want to change the map anymore at about 25%. Some places are 20, some are 30, but 25 is a really good rule of thumb. We really don't want to change that because, again, we're talking compensatory mechanisms. The only reason we really, really want to get this drug out is to treat because of a suspected or confirmed stroke. Right. And we really need to know that this patient is being affected poorly because of this, and that it's not a compensatory mechanism. This is a reaction then. The really nice thing is it has a short half-life. And so because of that, you can truly titrate this. Now, because it is so powerful, you must be checking your blood pressures all the time. I'm talking every 2 or 3 minutes, get that monitor fired up. That's what you have to do, because you can very quickly adversely affect a patient by dropping that blood pressure down too fast. The other problem is that sometimes, because, and I know I've touched on this before, cardine will actually lead to tachycardia. Mm-hmm. Okay, and this tachycardia, when we are talking about pushing blood or other fluids into areas of the body for which you don't want that, which one of those things is obviously in your head, right? If you have some kind of hemorrhagic stroke, or even if you have an embolic stroke or something, and you've got that embolism that's just sitting right there. You don't want all of that pressure to keep building behind it, because eventually it will break. Mm-hmm. So we also have to be making sure that we have to watch that heart rate. We have to make sure that heart rate does not start to go crazy on us. And the reason the heart rate is going to start rising is because, remember, this is a calcium channel blocker. Mm-hmm. Okay? Calcium channel blocker, you're going to block all those calcium channels, and calcium is a stabilizer for the cell. If that cell becomes less and less stable, it becomes more excitable. As it becomes more excitable, it wants to fire off faster and more often. And that's exactly what happens. That paired with, as you slow that heart rate down, you still have that oxygen demand. Mm-hmm. And so you have, even though you're starting to slow everything down, you have a higher demand with a more excitable cell. And then that's what will ultimately lead to sometimes you'll have some tachycardias going on that you got to be ready. So it is risky. It is a drug that you have to be very, very cautious about. You have to know a lot about it, and you have to know a lot then, if things go wrong, how to take care of those things. And so there's a lot of people that stray away from that because of that, because there's a lot going on with that patient that you have to manage.
That's probably why, it is one of those things you have to call for orders on. Mm-hmm. So let's just say you are giving them medication and you drop the patient's blood pressure and you get a little reflex tachycardia going on. I mean, what do you do to fix it? How do you manage this? Do you start flowing a bunch of fluids in to fix the volume? Because, no. I mean, if we've got a suspected stroke, that's not the thing that they need, especially what we're giving. I mean, what do we do in that instance?
Well, thankfully, cardine doesn't last very long. So, honestly, it's turn the pump off.
Yeah.
And wait.
And wait. They're already hypertensive, right? what we're looking at is changing the map from a super high number to a less super high number.
So it'll just rebound back.
It's going to go back up.
Easy enough.
And so it's one of those things that you have to be watching for, but it is easy to deal with in some cases. Now, if that heart rate does start getting out of hand, you have to start considering maybe stopping that and then starting something like a beta blocker.
Sure.
Or going into whatever your policies or procedures, or call for orders for something at that point, and that doctor will be able to kind of guide you that way.
So cardine is a dihydropyridine agent.
Oh, there's that word again.
Bringing that back out. It's important for us to know as much as we possibly can about the things that we have on our tool belt. Dihydropyridines, they're going to exert minimal effects on the myocardium itself. They're primarily just going to be peripheral vasodilators. In cardine specifically, its job is to relax the smooth muscles of the vessels, and specifically the arterioles is where it likes to act. So this drug does a phenomenal job for what it's designed to do. And that's why we get such a great response out of it, is it's just going to relax those vessels and provide more area for the blood to go into, and thereby reducing that pressure. And we were talking about its half-life. Its half-life is only 34 minutes, which is great. Duration, 15 to 30 minutes. A really quick onset with that.
So, there may be some medical directors out there that are practicing this trait. We hear it once in a blue moon when we're talking about medications and lowering blood pressures. And there are still doctors out there that are giving, and you won't see it on this table right now, but nitroglycerin to lower blood pressure.
Yeah.
I mean, old school medicine right there of just give them a sublingual dose of nitroglycerin, because we know that is a side effect of the medication. But that's not good medical practice.
No, definitely not.
So why do you guys think that they were doing it versus now we're not?
I like to look at it from a historical perspective.
Imagine that.
So, are you aware of why we even know why nitro does its thing?
Yeah, well, it's a vasodilator.
But why? Where did we figure that out at?
Well, it comes back to the reason why we have to ask the magical questions. We have to ask these patients on, have they been taking a certain medication?
Yeah, but we found out that nitro has these properties because they were taking nitroglycerin into mines and blowing stuff up. Mm-hmm. And they found out that these guys that were mixed, because you used to have to mix it on site and then put it into those tubes that you see, and then you would go in and blow up your rocks and things. And they found that these guys that was handling everything, they thought, it's no big deal. It's not. This is the 1800s. They're not wearing gloves. We don't know what nitrile is. I mean, they barely have rubber, right? So they're going in. They're just mixing this stuff with their hands, and then occasionally they'll just pass out.
No big deal.
When they passed out, somebody decided, let's start checking their blood pressure, and they actually found that these guys' blood pressure was lower than the acceptable range, which I don't know what they thought of. It was at the time, and we're talking 1800s, so a long time ago. But they found that they had low blood pressure, and they actually started to think, people with high blood pressure, just give them this because it fixes it. And that led then to it just staying in the vernacular of, especially when we start talking about medicine, let's just keep doing it because we found this thing, right?
It worked once upon a time, so why stop?
Sure. I mean, we talked about epi, right? Figuring that stuff out 100 years ago, what it did to those poor dogs, and we're still doing it, right? Why not keep doing it now? Mm-hmm. And one of the big problems, and that's why it persists. But again, one of the problems is it's taking away those compensatory mechanisms, and it's creating a problem that's not there, honestly, right? So we're going to vasodilate you out, whereas previously you were not. And yes, it gives us a better number. We can all high five our friends and we'll say, "Hey, look what we just did for our patient. Look, they must have better. They have better numbers. That means we fixed it, right?" No, all you've done was just push the problem off and perhaps even created another one. Because remember when Sam was talking about not changing that map any more than 25%, nitro will change that in big ways for some people. And that is a very dangerous road to go down with your patients, especially when we're trying to maintain at least some of those compensatory mechanisms, because they've got to be there, right? There's something else that's occurring, and by doing this, we're saying we don't really care what the problem is, right? We're just going to solve it any way that we can.
Yeah, and so American Heart Association has even pulled it from their hypertensive encephalopathy policy, and then they're saying, realistically, we know that with nitroglycerin, it's a vasodilator. So if we start dilating the cerebral arteries, we're gonna have a problem there, right? So we don't want to cause any more stress to injury on what we were using it as a side effect versus what it actually is intended to be doing, which is realistically using it more on the angina side and our cardiac patients and that source. And we'll talk about that in later sections as we get to that. But nonetheless, I wanted to bring that up because that is the most common thing that we hear is like, well, my medical director still has that in our protocol. Well, your medical director should probably read the NIH at some point and get some education on.
Absolutely.
But nonetheless, I did want to bring that up. Do you guys have anything else to add to any of those three drugs before I switch roles and kind of go a different direction with medications?
I'd just like to bring up the reason, right, behind the hypertension in your stroke patients. Your brain is not getting blood, whether it be from a hemorrhage or an occlusion. So it's telling your heart to pump harder and harder and harder to try and get that blood up to the tissues where it needs to be. And sometimes that pressure could be enough to help to alleviate some of that ischemia. And when we go to start trying to manipulate that blood pressure back down, you could be taking away from the body's own compensatory mechanisms. So, like we were saying, we don't want to we don't want to drop it down too much, because we know that the body is doing a decent job at trying to keep its brain perfused. So, just be cautious and monitor for worsening altered mental status or other stroke deficits whenever you're given that drug as well.
Yeah.
And they've also shown that in some of those studies that it'll actually create more clots.
Sure.
And obviously, if it is an ischemic stroke or something like that, and we're out there creating more clots or putting them in a situation where, okay, now they've got a clot somewhere else, like that's... we're not doing anybody any good.
Oh,
right?
man, I'm starting to see a STEMI now. Huh?
Yeah, whoops. Now they can't breathe real well. They got a PE or something, right? None of that's good. So, and here's the other thing, and this is going to lead into what we're going to bring up next, is we have to always take care of the kidneys. And by messing with all of this map and these pressures and all this stuff, I know I have talked to you all about taking care of the kidneys, especially when we were talking about acid-base balances and pH levels. It all comes back to satisfying the kidneys. And if the kidneys are hypoperfused, which means the blood pressure is too low to perfuse them, they're not working.
Yep.
They're not doing anything. They're also don't like too high of a blood pressure.
Yep.
If it's too high, they're still not working. They're not happy. And so we have to thread the needle with not just neurological impacts and things like that, but we also have to make sure that is the case. And that leads us into what we're going to bring up next, I think.
Yeah, and when we're talking about major organs, when we talk about shock and perfusion status, the kidneys are one of the most important things that we see. They will slow down and eventually stop working as a result. And so I like that you bring that up. So let's talk about this drug that we are seeing slowly but surely go away from the pre-hospital setting. I've got lots of information on it. And you're probably wondering, how does furosemide end up being in this antihypertensive emergency? Well, realistically, we're thinking volume overload. We got to get rid of some volume so that we can decrease, right? So I like to think of it as, if we're pumping fluids in to raise the volume to increase blood pressure, then we need to reduce it. Let's take some fluid away.
Yep.
Now, that's where furosemide can be very helpful if that is the problem, meaning we specifically know we have a volume overload. And typically, we like to classify those patients with our CHFers. But, going backwards a little bit, the most common cause of cardiogenic pulmonary edema is a cardiac dysfunction, whether it be a dysrhythmia or some kind of valvular insufficiency or damage to that left ventricle, whether it be chronic or acute, realistically chronic, because that's what CHF is. It's characterized by the significant changes of that left ventricular structure. So it's going to lead to problems with cardiac output and ejection fraction and things of that. But traditionally, when we get called to these patients, while it says congestive heart failure and we're thinking cardiac disease, realistically, we're always called for some kind of respiratory disorder, like I can't breathe or things of that sort. It's never because, sometimes we do get that my legs are weeping and they're swollen and they hurt, but realistically, that's just a side effect of the disorder. It's not because, they just want to go get checked out for the cardiac aspect of things. That being said, Adam and I were having a conversation about this in the office, and it was like, we understand volume overload, right? But these patients are not always having a volume overload. They're more or less having a volume distribution issue. So their problem isn't that they have too much fluid, it's that it doesn't go where it needs to go. And so as a result, maybe it is down in the peripheral area, and we need to plop their legs up or put some compression socks on or put the beautiful things you guys have in the hospitals that squeeze their legs. I cannot think of it right now. But with that, if we don't have adequate cardiac output, well, then what system is not going to work very well? Our renin, our angiotensin 1, angiotensin 2, our whole RAS system is just not going to work. And now we're going to have issues with sodium and water retention, because we all know the sodium comes out, potassium comes in, we've got to make everything great. If we have it not working, sodium is going to swell up the cells, and then we're going to get swollen, and hence why you go eat those French fries at McDonald's and all of a sudden your mouth is dripping. I need something to drink now because you have so much sodium going on. We got to off balance everything. So with that being said, Adam, I know we talk about it. It is all about the kidneys in this sense. If we have a lack of perfusion going as far as the kidneys go, and we throw in this drug that isn't for a volume overload problem with these patients and more of a distribution, we're just wrecking those kidneys even more.
If it works.
If it works. The key word there, if it works. Because we know it's not a fast-acting drug either. It is something that's going to take time, and most of the time our patients are already on a diuretic of some sort. So now we've got to chase their dose on top of our dose and then wait for it to work and be reassessing and reassessing and reassessing. But nonetheless, it's got that slow action, and it's a lack of consistent benefit. And so, we'll do other things to help the reabsorption and distribution. Maybe it's by CPAP, or maybe it's with nitro, and we'll talk about that later. But none of us know in the field if it is a volume overload or a volume distribution problem, because we aren't doing BNP testings in the field. We're not looking at kidney function. Mm-hmm. Tyler, you will be when they get to you, but not so much us. We might draw for it, but we're not going to actually read it.
One day, you'll have an iStat on your box.
One
day.
Some of them are getting there, but...
Yeah, and this whole talk, a lot of what Sam just said should sound very familiar to you about many conversations that I've had with y'all about the acid-base balances, about the kidneys, about how all this stuff works. Now we extrapolate that out to starting to affect this. And when we start talking about, CHF, and we start talking about trying to treat it, just like long-term fluid use, one of the things is that we don't know what their electrolyte situation is. And if their kidneys are still working, and their kidneys are able to then respond to the dosage or to the Lasix that we're going to give it, then we cannot control, because it's up to those kidneys, how much fluid those kidneys are going to excrete. Mm-hmm. right? And we know that with the fluid, there's more than just water, right? There's all kinds of things. There's sodium, there's potassium, there's magnesium, there's calcium. All of that stuff is going to then leave. And we have no idea where they're at.
Yeah.
And one of the big problems downstream, not that we see it very often, or, because again, Lasix takes a while to see it, these patients then have to have this stuff added to them.
Yep.
Mm-hmm.
And one of the other problems with when we don't know what their electrolyte status is, then we can pull all those electrolytes out, and then they start having other arrhythmias, right? So we know that congestive heart failure is a problem of the pump to be able to even deal with the fluid that they have. So, and that's why it's not necessarily a fluid problem. They have what they need. They have what they have in a lot of cases.
Yeah.
Problem is they just can't deal with it. They can't move it around. It gets sheared off at the cellular level and then falls to the base point of the body, and it just sits there.
Mm-hmm.
Now, when we start talking about then we take all these electrolytes out, then we start having other problems with an already sick heart that can't deal with what's happening anyway, and then the cycle continues. The other thing is a lot of these patients, they're kidney patients. They become this way because of the use of so many diuretics, right? We think we currently are trying to balance their fluid intake versus their fluid out. And so a lot of these patients are on fluid restrictions, and they're pulling out so much off of them and only letting so much in, and all this other stuff. And it doesn't matter really if it's done by machine or done by drug. Their electrolytes and everything else are always a challenge. And our problem is we can't manage that.
Which is probably why we get a lot of calls to our dialysis centers for generalized weakness, dizziness, but most importantly, we get a lot of cardiac chest pain patients out of there. You start messing with those electrolytes, it's going to throw everything off balance, like you're saying.
Mm-hmm.
That's primarily, and they're always right in the middle of their session. So it's always great to ask them, what was their pre-weight versus what did they weigh when we're coming out of here? How much volume did you take off? Where were you at with this? All the questions you should be asking these dialysis centers when you get in there, and not just taking them and running out the door, because they're not done with dialysis. They have to continue this when they get to the hospital setting, and the last thing you want to do is take more than they should, and now we really throw things off. The other spectrum of that is when you're talking about we start changing electrolyte balances, we can only see, like Tyler's saying, we don't have eye stats in the field. I mean, we're getting them slowly but surely, but we can only measure electrolyte imbalances by one way, and that is cardiac monitoring. And we're looking at those specific things. You got your peak T waves, and you've got hyperkalemia going on. And so we look at it from the other side. If you have hypocalcemia and talking about all those, but nonetheless, it's like, that's not an immediate thing. I mean, it has to be significant for us to see those things.
There a lot of times when we see it, it's already behind the eight ball.
Yes. It's like when we talk about diagnosing STEMIs in the field, it means that we are literally seeing it happening in that very moment that we get to catch that glimpse of it. It's not something that's going to happen over time. It's like watching the eclipse in the sky, right?
Mm-hmm.
You get to see it for a minuscule, and that's it. But 9 times out of 10, you take them to the hospital setting, they can start seeing the trending of their troponin levels and CKMB and coming up, and they're watching this factor that we can't quite see yet on a cardiac monitor until the mecca of all things are happening.
Yeah, and that's this leads to one of my big things is that, honestly, when we show up and we start putting 12 leads on people that are having chest pain, we cannot tell them that they're not ever having a heart attack.
Yeah.
Right.
We can tell them if they are, but we can never tell them if
Yeah.
they're not. And that's one of my big bugaboos. Is that
Always-
we can't look at it and say, you're fine, doesn't show
Yeah,
anything.
no, I'm always like, not at this very second,
That's
but
right.
that doesn't
Yeah.
mean that you shouldn't still go get your labs evaluated.
And I would wager that if they have all the signs and symptoms, you should still consider and treat it as an MI. And we know that there's a STEMI and an in-STEMI. Just because there's no STEMI does not mean it's a MI. It could be just as bad as a STEMI without the elevation. So
we know that, like, furosemide, we obviously know it's a diuretic, but it comes with the trait of it's a loop diuretic. So what does that even mean? Is it just going around in loops and loops and loops, or?
It's one of my favorite loops.
The
The
loop-de-loop?
loop of Henle.
Ah, tell me about this loop.
So the loop of Henle, that's what is essentially in your kidneys that's regulating this. It's the decision maker. It's reading how much sodium, how much volume, how much fluid, whatever, and it's taking whatever out and leaving whatever it wants in, and that's where all the magic is happening, is inside that loop of Henle. And what Lasix is doing is it's going in there and stimulating that loop. And once that loop becomes stimulated, the thing it wants to do is get rid of volume. It wants to get rid of any of that fluid. And so it's not, we're not talking about like a hula hoop loop. It's more of a J, actually. If you look at it under a microscope, it's not really a hoop at all. But but they call it the loop of Henle, and that's really what we're talking about when we start saying this is a loop diuretic. We're just talking about that part of the kidney is what is being affected by that drug.
Yeah, I think, we know in good traditional practice, if you have a CHF problem, and like we were saying, it could very well be that we're getting called for the respiratory aspect of it because of some volume distribution issues or shortness of breath or things of that sort. And we'll know our patients when we see those in a really good thorough assessment to make sure we have a CHF patient and not a COPD exasperation. Two very completely different patients, wet versus dry, and listening to our lung sounds and evaluating that patient. Specifically, chronic bronchitis normally gets confused with the CHFers, and don't go down that pathway. But nonetheless, CPAP is our first line that we go to, and then we get into nitro and morphine, and then back in the day was the Lasix aspect of it. And there are probably still some medical directors out there that have it on the ambulance. And we'll talk more about the nitro and morphine when we get into the acute coronary syndrome. But, in an essence, we're trying to reduce vascular pressure and through the vasodilation of those medications. And then if it is a volume problem, we'll use the diuretic to get rid of that excess fluid. That's essentially what its job is.
Yeah, and like we said earlier, one of the problems is we don't know.
Yep.
And so by stimulating that loop of Henle and getting rid of that excess volume, if they needed that volume in the first place, now you've done them a disservice.
Yep, absolutely. Do you have anything else you want to add to that?
Yeah, so I was just reading about some of the other effects of furosemide. So, yeah, we know it's diuretic. But what you might not have known is that furosemide can actually cause a little bit of vasodilation. So studies have shown that after about 5 minutes of administration of this drug, there has been some vasodilation from that. And while this might not be enough to get you to where you want to be as far as blood pressure goals go, that is something to take into account when you give this medication, and you might notice a blood pressure decrease. Don't immediately think, oh man, it's already working, and check the bed for pee. No, it just something to take note of is that you can have a decrease in that blood pressure pretty quickly after it's administered.
Do y'all have anything else on these antihypertensives that you guys want to add that we maybe missed?
I think we've pretty well discussed them.
I'm good.
All right. Well, that's a wrap on this episode of the Weatherford College EMS Podcast. Big thanks for tuning in as we kicked off our talk on antihypertensives. It's a topic that can feel intimidating, but we promise it gets clear with every call and every repetition, from Tyler, the NIH man, or Adam to the historian, or myself from the field-tested perspective. We're here to guide you through it every step of the way. Stay curious, ask questions, and never stop connecting the dots between the meds, the pathophysiology, and the patient. Until next time, stay safe, stay smart. Don't forget, it's not about just knowing the drugs. It's about knowing what they do and why. Have a good day.